Hello everyone, I'm Dr. Divya Gupta, your original guru for Periodontics, and today we are here for the final INI GT discussion, that is GT-4, right? So just say hi in the Telegram group so that I can start the session, or say start so I'll know how many of you have joined and we can start. I know 2 people are going to join, Sudhashri and Rani James. You both can give me a thumbs up at least. And then we will start this session. Okay, just say that I'm audible and clearly visible, guys. Then we will start this discussion. Shall I start, guys? If you all are watching me, guys, please reply in the Telegram group. That is more feasible for us, to communicate. So if any of you have joined, please say start in the DBMCI group on the Telegram. And then I'll start the session. I'll wait for a few minutes and then I'll start the session. So at least say hi, hello in the Telegram group. Okay. I'm not able to see the app directly. So please message in the Telegram group. Please post your doubts, any of your questions, queries, and whatever answers you want to give. Please post it in the Telegram group. Okay. Any of you have joined till now? अरे ऋषभ, किसने ज्वाइन किया है ये सेशन? नहीं नहीं, कोई रिप्लाई नहीं आ रहा ग्रुप में, इसलिए मुझे पता ही नहीं चल रहा किसी ने ज्वाइन किया है कि नहीं किया है, इसलिए ठीक है, चलो। स्टूडेंट्स, okay students, then I'm starting the session, and in between if any of you have any doubt you can ask. Basically most of the times I don't think anybody has joined till now, so I'll just go on with the question and answers and the explanation. Okay. Otherwise, if any of you are seeing it live, can ask me in the Telegram group. Then I'll go like first the question, the options. I'll wait for you all to answer and then we'll move forward. Otherwise, I'll just say the question answers and the discussion part. Okay. So let us get started. The first question is, which amongst the following is the disadvantage of full thickness flap? Which among the following is the disadvantage of full thickness flap? Now, what is full thickness and partial thickness flap? Okay. The options are some bone loss is seen. Option B, more shrinkage of the flap is seen. Option C, better match with the skin color. And option D, both A and B. So, here the answer to this question is option number B, that is both A and B. Now, let us see first what is a full thickness flap and what is a partial thickness flap. Okay. So, a full thickness flap means if this is the tooth, if this is the tooth, okay. And here there is bone, okay. Here there is bone. Above that, above this, there is a flap, right? Here there is a gingiva. Above this, there is a gingiva. Now, between the bone and the gingiva, there is a layer called periosteum. Okay. So, this is gingiva. This is gingiva. And this is periosteum. Now, in full thickness flap, what we do is whole of this gingiva along with the periosteum, we separate it from the underlying bone. So, what we do is whole of this gingiva, this part is separated along with the periosteal lining of the bone. So, this is your full thickness flap. This is the full thickness flap. Full thickness flap. Okay. Full thickness flap. Now, in partial thickness flap, what we do is this is the tooth and here is the bone. In this partial thickness flap, the periosteum, the underlying periosteum is not elevated. The underlying periosteum is not elevated. In partial thickness flap, partial thickness flap, underlying periosteum is not elevated. Okay, so we are not separating it, we are just removing a part of the epithelium and the connective tissue. Okay, a part of the epithelium and the connective tissue and the periosteum that is covering the bone is as it is, and the periosteum that is covering the bone is as it is. So, how this will look is the periosteum is covering the bone completely. It is not elevated. Some part of the connective tissue is also attached to the periosteum. Okay, it is also not elevated, and only some part of the epithelium and connective tissue is elevated. So, mostly partial thickness flap is taken in cases such as mucogingival surgery. When we have to do mucogingival surgeries, at that time we'll take partial thickness flap. And full thickness flap is taken when we need to do any underlying bony procedures like infurcation, if we have to do any bone resective surgery or bone regenerative surgery, any treatment of the furcation. Okay, in those cases we do full thickness flap. Now, in full thickness flap, the advantage and the disadvantages. The advantage of the full thickness flap is it has a good color match. The color match is good and we are able to see completely the underlying bony structures. But the disadvantage of this is that there is some amount of bone loss. As we are raising the whole flap along with the periosteum, now some part of the bone is lost. So one of the major disadvantages is this, and the other is when we suture back this full thickness flap, there is some shrinkage of the flap seen. So these are the two disadvantages of the full thickness flap. Okay. Okay. Hi. Some of you have joined. Rani James has joined. I was waiting for you. And now, okay, so first question we have completed, Rani. Which amongst the following is the disadvantage of the full thickness flap? I hope you have seen the discussion. Okay. If you have any doubt in this question, please ask me. Now, I'm moving to the second question. The second question is, which area is more prone to accumulate plaque bacteria? Which area is more prone to accumulate plaque bacteria? Option number A, occlusal. Option number B, interproximal. Option number C, buccal. And option number D, lingual. The answer to this question is, guys, I think only one or two people have joined. So if you can answer, it would be nice. Yes, the answer to this question is B. Which area is more prone to accumulate plaque bacteria? It is interproximal area. In the interproximal area, what is interproximal area? The area which is located between the two teeth. Okay, in that area, what is there? There is caul. What is there? There is caul. Now, the property of caul is, so why this area is more prone to plaque accumulation? Because it is difficult to clean. Number one reason, difficult to clean. Number second reason is there is presence of caul. Now, in the interproximal region, where there is caul, okay, this is the gingiva. Here is the caul. This caul area, it is a non-keratinized area. This is a non-keratinized area. It is highly colonized by bacteria of the plaque. Highly colonized by bacteria of plaque. Okay. So, whenever you will see a bone loss or a periodont, whenever you are checking for a periodontal pocket, most commonly in cases of periodontitis, you will find deep pockets in the interproximal region. You will find vertical bone loss in the interproximal region. Okay. Because that area is more prone to plaque accumulation. Okay. Now, the third question. All these changes are seen in maternal immune response. Mark the keywords. Just remember that as in when we are reading the question, keep marking the keywords. Here, the maternal changes seen in the maternal immune response due to progesterone and estrogen, which leads to increased gingival inflammation in pregnant patients, except. Now, the most important part here is the except. So, we have to find the reason which is not causing increased gingival inflammation in pregnant patients. Okay. Now, the options are option number A, depression of cell-mediated immunity. Option number B, decreased neutrophil chemotaxis. Option number C, increase of antibody and T cell response. Option number D, decrease in the ratio of peripheral T helper cells to T suppressor cytotoxic cells. That is, decrease in the ratio of CD4 by CD8 ratio. Okay. So, the answer to this question is, Rani, James. The answer to this question is option number C. So, we have studied this before also. What happens in progesterone and estrogen? What happens during pregnancy? In pregnancy, what is happening? There is increased chances of gingival inflammation. There is increased chances of periodontitis. Why? As a response to progesterone and estrogen, there are certain changes that are occurring in the plaque bacteria. One thing, the physiology of the gingiva. Second, and the third is the response, the immunoinflammatory response of the mother. So, here it is asking about the changes that are occurring in the inflammatory response of the mother. You should remember that the immune system of the body is responsible to fight against the bacteria, right? Now, in pregnancy, what happens is pregnancy is a condition in which the immune response decreases. The immunity of the patient, the women, is decreased during pregnancy. So, the mother is more susceptible to diseases. She is more susceptible to periodontal changes. Okay. So, depression in cell-mediated immunity. T cells and B cells are responsible for phagocytosing the bacteria, for identifying the bacteria. They are responsible for producing the immunoglobulins against the bacteria. Okay, so if the T cell and B cell mediated immunity is decreased, the mother is more prone to periodontal inflammation, right? So this is one of the reasons which can cause increased gingival inflammation. Decreased neutrophil chemotaxis. Now, all of us know that neutrophils are responsible in the initial cases, right? In the initial time, first 2 to 4 hours, which cells are responsible for phagocytosing the bacteria in acute cases? First the mast cells and next the neutrophils, right? So neutrophils, they will undergo chemotaxis, they will reach the bacteria and they will phagocytose the bacteria. Okay, so decreased neutrophil chemotaxis means the neutrophil will not be able to reach the bacteria. There will be no chemotaxis of the bacteria. Chemotaxis means the bacteria will release certain toxins, certain chemicals, which will be identified by the neutrophils and they will be attracted towards they will know that the bacteria is here and they will reach there. Okay, so that will be decreased in patients with no worries, no issues, Rani, no issues. Okay, I saw I'll show you a chart also. Actually, that chart is not here. After the lecture, I'll post it in the group. You can see that that is from Karanza only. In that, they have given all the changes. That it is a big chart. Okay, so you just have to be clear with the basic concept. And if you feel that you are not clear with the concept, because pregnancy and gingival changes are very important, and if you feel that you need to read it in more detail or anything you need to ask, you can message me. Okay, no issues there. Okay, so the neutrophil chemotaxis is also decreased. Option number C, increase of antibody and T cell response. Now, already we have seen that cell mediated immunity is decreased in patients with pregnant patients, right? So, cell mediated means two cells are responsible for immunity. That is the basic, right? B cells and T cells. So, if they are decreased, how can B cell is responsible for producing antibodies, right? Immunoglobulins is produced by B cells. So, if B cell is decreasing, how can there be an increase in the antibody and T cell response, right? So, increase is not respond. Instead of this, it should be decrease. Decrease of antibody and T cell response is seen. And option number D, decrease in CD4 to CD8 ratio. This is also true. The CD4 cell count decreases in patients with pregnancy. So even if you're not, one thing I'll tell you, even if you have no idea about what the question is asking and what is it, I don't know this topic very nicely, what you can do is, see, it is about immunity. Immunity, all of us are reading since our first year or second year, I'll say second year pathology, right? So what you have to think is, okay, ये immunity का question है. This question is from immunity. And in pregnancy, option number A is depression of cell-mediated immunity. अच्छा, cell-mediated immunity decrease हो रही है. The first question is saying that option. Second is decrease in the neutrophils. So everything, all the three options are pointing towards decrease in the immunity, right? Only one option is odd one out. Only one option. Option number C is odd one out. It is only option which is pointing towards increase in the immunity, right? That way also you can think. Three options are nearly similar and all of the three options are pointing towards decrease in the immunity. You need not know the exact answer. You need not know anything. But by reading the question, you know that this question is for immunity of pregnant patients. And out of the four options, three options are showing there is decrease in the immunity. So, what is left? Only one option is left and that is your answer. That way also you can answer this question. Okay? Understood? If there is any doubt, ask me. Question number 4. According to Merrin's classification, class A recall schedule of maintenance visit should be after. This is a direct question of Merrin's classification. Okay. I'll tell you I have told it many times that how to remember Merrin's classification, because by seeing Merrin's classification, we'll see it is not Merlin, it is Merins classification. By seeing Merins classification, we'll feel, अरे यार इतना बड़ा table है कैसे याद करेंगे, right? Every one of us feel. I used to feel the same. But you need not remember the whole table. You just need to remember the keywords and the months. That's it, and nothing else. So, according to Merins classification, class A recall schedule of maintenance visit should be after option number A, 1 to 3 months. Option number B, 3 to 4 months. Option number C, 6 months to 6 to 12 months. And option number D, 1 to 2 years. Okay. So, I'll just discuss the what is Merins classification, and then Rani, you have to give me the answer. Okay. I'm discussing first the Merins classification. So, in this, according to Merins classification. Now, what is Merins classification? I hope you all know. Merins classification is a classification for recalls. Means I have done all the treatment that was necessary, whether it was scaling and root planing alone, or there was tooth extraction, there was periodontal surgery, there was gingivectomy, anything. Not only pertaining to perio, pertaining to any, means root canal was there, prosthesis was there, anything was there. So in the first year, suppose the patient came to me on January 2024. So for till January 2025, if the patient has uneventful healing and the patient's oral hygiene and everything was good, only few minor treatments were done, then in that case, you have to do follow-up at every 3 months till 2025 January 2025, right? But if you think that the case was difficult, it was, there were multiple extractions, multiple prostheses were given, periodontal flap surgery was done for the patient, implant cases, in such cases, full mouth implant cases, full mouth rehabilitation cases, in such cases, you have to do a recall at every 1 and 2 months. Every 2 months is suffice, right? So why you are doing the recall? You are doing the recall, number one, to motivate the patient. Okay, you are motivating the patient at every recall. You are motivating the patient to maintain a proper oral hygiene, to do proper cleaning of the oral cavity. You can show the patients that where the inflammation is still there, where you are not maintaining a proper oral hygiene, which other part needs treatment still. Okay, so you can advise patient according, and you can monitor their habits, their hygiene habits, right? During a recall. And if you feel during the recall, if you feel that for 1 year the patient has maintained a good oral hygiene and the condition, the periodontal condition, the condition of the whole oral cavity as such was nice, then in the consecutive years, in the after January 2025, means after the completion of 1 year, you have to do the follow-up, like you have to classify the patient as class A, class B, and class C. Now in class A, you have to remember only one keyword, excellent. Okay, you have to remember this keyword. Excellent results are maintained for 1 year. That's it. The patient is maintaining excellent results, good oral hygiene, koi problem nahi hai, everything is fine. Then you have to do the recall at 6 months or 1 year. So twice in a year or once in a year, you can call the patient after first year. If you feel that the patient is maintaining good results, so here the keyword is good results for reasonably 1 year, but sometimes, some patients have a tendency of forming rapid, means heavy calculus formers are there. So they are forming calculus very, frequently, though they are trying to maintain their oral hygiene. Still some areas there is uh, calculus formation, some, trauma from occlusion cases. In such cases, means in difficult cases, you can recall the patient in 3 to 4 months. That is class B. And in class C, means the keyword here is poor results. Don't remember all this. You need not remember all this. These things will not be asked in the exams. Either they'll ask you class A, class B, class C, or they'll ask you the keyword. The patient is maintaining the good results. Patient is maintaining excellent results. Patient is maintaining poor results. Okay. So based on these keywords, you have to remember the months. So for excellent results, 6 to 12 months. For good results, 3 to 4 months. And for poor results, 1 to 3 months. You have to do the recall. Now tell me the answer. According to Merins classification, class A recall schedule of maintenance visit, means after 1 year, when the patient is being recalled, What should be the answer? The answer to this question is option number C, which is 6 to 12 months, right? Class A, they have directly asked the question. Class A. Class A means 6 months to 1 year. Okay? Understood? Now the next question. Okay. The next question. The below image shows modification of which curate? The below image shows modification of which curates? So, there are 4 curates seen, and in each curate you will see some difference. I'll tell you the difference also. This is the first curate. This arrow shows the shank and this arrow shows the tip. Okay. This is the second curate. Now here you can see that the shank is little bit extended. It is elongated, right? But the tip arrow is same. In the third, the shank arrow is the same, but the tip arrow, this arrow, it has decreased. This tip arrow, it has decreased, right? And in the fourth one, you can see that the shank arrow is same, but the tip has still decreased. It is, I think the arrows are same in size, but actually you can see visually also that the tip length here is this much, right? The tip length here is this much. The tip here is this much, and here it is very small, right? So these are the modifications of option number A, Gracie curate. Option number B, universal curate. Option number C, Langer curate. And option number D, Gracie curvates. So these are just a modification of a curate. So you have to tell me the answer. The answer C is for fourth question or question number fifth. The answer to this question is option number A, dear, Gracie curate. So, Gracie curate has three modifications basically. Initially, the Gracie universal curates were made. Gracie curates means area specific curates, right? Gracie curates are area specific curates. Now, in area specific curates, the scientists elongated the shank. Why this shank was elongated? So that it can reach the first modification. The first modification, the shank was elongated. Shank was elongated. Okay. Why this shank was elongated? So that it can reach deeper areas. It can penetrate deeper pockets, reach more deeper pockets to for this the shank was elongated. So these were also called as extended shank curates. Extended shank curates. Or you can say that they are also called as after 5 curates. Sorry. After 5 curates. Okay. After that, what was done was the shank which was extended was kept extended. Second modification. This was the first modification. Now the second modification. In the second modification was what was done was the shank that was extended was kept extended, but this tip was reduced to half. So the tip length the tip length was reduced to half. Okay. So when the tip length was reduced, what was the benefit? It can go into the narrow areas plus the deeper areas. It can reach the percussion areas. It can reach the grooves very nicely. Okay. So this was the advantage. The third modification was the tip was even smaller. It was micron. It was in micron meters. So the tip reduced further. These were called, so the second modification was called as mini 5 curates. The second modification was called as mini 5 curates. Mini 5 curates. And the third modification was called as micro mini 5 curates. Okay. By reducing the tip further, the added advantage was now it will be able to go into very, very small areas. Okay, mostly these three are not that much that commonly used, not that commonly used. Most commonly we used only Gracie curates. Okay, so this is Gracie, this is after 5, this is mini 5, and this is micro 5. Okay, so these are the modifications of Gracie curates. Now the next question is question number 6. Piezoelectric scaler moves in which motion? Okay, piezoelectric scaler moves in which motion? Option number A, a very frequently asked question, and many a times it has been repeated. So the answer to this question is option number A, elliptical. Option number B, linear. Option number C, crosslinear. Crosslinear, and option number D, circular. The answer to this question is, guys, the answer to this question is C, piezoelectric scaler. The piezoelectric scaler, I'll show you the movement of all the tips. The answer to this question is option number B, that is linear. Okay. Now the ultrasonic piezoelectric scaler is a type of ultrasonic scalers. Okay. Ultrasonic scalar. Ultrasonic scalars are of two types. Magnetostrictive. Magnetostrictive. And piezoelectric, right? Piezoelectric. Now this magnetostrictive, the tip moves in the elliptical direction. The tip moves in the elliptical direction, and all the surfaces of the tip, are working. Means you can remove the calculus from back and front end, though only lateral surfaces should be used, but still it can be removed. And in piezoelectric, the movement of the tip is linear. Only it has two working surfaces. It has two working surfaces. Okay. If any doubt, you can ask me. Now the next question is, which of the following is a non-resorbable membrane? Which of the following is a non-resorbable membrane? Now these membranes, what this membrane is? This membrane is the membrane which is used for regenerative procedures. Regenerative procedures. Today I'm not getting any response in the Telegram group. So it's like it is just a one-way thing that is going on, guys. I usually don't enjoy this, but it is a session and we have to complete it in 1 hour. So I have to continue. I'm also like a little bored while teaching because, most of the times I'll be getting questions and people will be answering me. That is more interactive and we also enjoy. We as tutors, we as a faculty also enjoy doing this. But today, I don't think any of you have joined, or I'm not getting any response in the Telegram group, basically. So I'll just go a little bit faster only. Which of the following is a non-resorbable membrane? So resorbable membranes are used basically for regenerative procedures. So previously, nowadays, all the membranes are resorbable only. But previously, there were some membranes which were used and they were not resorbable. So to remove those membranes, also a second surgery was required, which is not good, right? If we are again and again opening the gingiva, what is going there? We are creating a trauma and there is more and more bone loss and there are more chances of infection. So to prevent those complications, resorbable membrane were developed. So the most commonly used non-resorbable membrane is polyester. Polyester. The answer to this question is option number A, that is polyester. Now option number repair types and lasers, ma'am. Okay, I'll tell. No issues. And lasers. OMFS aims repair, I can tell you, but we have a session only for 1 hour. Laser is a very big topic in itself. There is a recorded video on that. We can keep a what if anything specific you want to know in laser, I can help you with that. Just tell me. Repair is a short topic that I'll tell you at the end. But in lasers, what specifically you want to know, just tell me that. I'll tell you that. Okay. Now, option number 8. Correct about the following probe. Correct about the following probe. This is a probe, image-based question, right? An image-based question. This is, you can see the probe, just see that it has a ball end and a marking. Okay. This is only what is important for us. Now, option number A is, is it a WHO probe with marking of 3.55, 8.5 and 11.5? Is it a WHO probe with marking of 3.5, 5.5 and 8.5, 11? Is it a CPITN probe with marking of 3.5 to 5 or a CPITN probe with markings of 3.5 and 5.5? Answer. Anyone would like to answer this question or should I proceed? Because today I'm not getting any response. Okay, the answer to this question is CPITN probe with markings of 3.5 to 5.5. Okay, now tell me or just think whether CPITN probe and WHO probe different or they are the same. Yes, the answer to this question is D. And tell me whether WHO and CPITN probe same or different. WHO and CPITN probe, both of them are same. Sometimes I get a doubt in the group, what is WHO, whether the answer should be WHO or CPITN. Guys, WHO and CPITN are the same probes. They are not different. And CPITN is of two types. CPITN or WHO probe is of two types. CPITN community. What is the full form of CPITN? Community Periodontal Index Treatment Needs. Right. It is of two types. CPITN E and CPITN C. E is for epidemiological purposes and C is for clinical purposes. Now, this probe, CPITN-E, has a marking of 3.5 to 5.5. It has a marking of 3.5 to 5.5. And in C, you will see additional marking at 8.5 and 11. 8.5 and 11. Okay, so this is your CPITN probe or WHO probe. Both are the same. Don't get confused. This is just to confuse you and nothing else. Both are the same. Okay. Okay. OMF is aims. You want to know about hard tissue lasers and which are the soft tissue lasers, right? For the wavelength. Okay, that I'll tell you. That is also short. In short, I'll tell you that. And if anything else you want to know in detail, let me know in the group. I'll make a video for it. Okay. Now the next question. The image shown below shows what kind of bone defect. The image that is shown here shows what kind of bone defect. Whether it is a crater. Option number B, reverse architecture. Option number C, ledges. And option number D, infrabony defect. So here you can see that there is a depression and there is loss of facial plate and the lingual plate as well. Okay, the facial plate we can very clearly see. The radicular bone, it is as it is, and the interproximal bone or the interdental bone is completely lost. There is loss of in the last class also we discussed this, right, for the osseous craters thing, right? So the answer to this question is very good. The answer to this question is B. reverse architecture. See, don't reverse architecture or negative architecture. Okay. These two are the same thing. Now, many of you get confused between crater and negative architecture. So, just be clear that in crater, there is interproximal bone loss. The facial and the lingual plates remain intact. They are not lost. So, whenever there is a crater, you will see that here there is a bone, here there is a bone, right? Here there is a bone, here there is a bone. And in between, there will be a bone loss. So, whenever you will see the image proximally, you will see that the facial plate, this is intact and this is intact, but here there is a deep crater. So, this is a crater. Okay. But if these two plates are also gone, means those two plates are also lost and the architecture is somewhat like this. Okay, like this. Then this is a negative architecture. So concept समझ में आया? That I hope you all know the structure of the bone. The bone has interradicular bone and the facial plate, lingual cortical plates and the facial cortical plate, right? When the facial and lingual cortical plate is intact and there is interproximal bone loss only, then it is called as crater. Okay. But if there is loss of facial plate and lingual plate along with the interproximal bone loss and radicular bone, the bone that is covering the root surface of the tooth, this bone, it is intact. There is no loss of that. Then it is called as negative architecture. But suppose suppose this bone is also lost along with the interdental bone. This bone is also lost. Then you will get a flat architecture. So this will be now a flat architecture. Okay, understood? Now the next question. Bilaminar technique for gingival recession means. I was getting doubts regarding this question also. Okay. What is a bilaminar? As the name suggests, bilamella means two layered, right? Bilamella means two layered. So it is a recession coverage in which there is a usage of two layers. Two layers are used to cover the recession. So what can be the two layers? One layer definitely has to be taken from somewhere else. Only we can get one layer from the adjacent area. The other layer should be of something else. So it can be either a connective tissue graft, it can be either a free gingival graft, it can be either a PRF plus membrane. Many things can be used in bilaminar technique, but most commonly subepithelial connective tissue graft is used as one layer. Okay. Yes, the answer to this question is option number C, which is connective tissue graft plus coronally displaced flap. But guys, be clear with the concept कि क्या होता है basically bilaminar technique में. So basically what happens is one layer of most commonly what is used is we are talking about the most common things. Okay. Otherwise we can use many other things in bilaminar technique. But in the exam, most commonly for you all, the common things will be asked. So commonly for you all, you have to remember only one thing. What happens here is don't go for exceptions. Most commonly we use for bilaminar technique subepithelial connective tissue graft. Okay. Subepithelial connective tissue graft. And secondly, a pedicle graft is used. Now remember that pedicle graft. A pedicle graft can be used. What is a pedicle? Pedicle is a flap. This pedicle graft can be of two types. Actually, it can be of three types. Coronally displaced, apically displaced, and laterally displaced. In recession coverage, we will not be using apically displaced flap, right? So we will be using a coronally displaced graft, either a coronally displaced flap or a laterally displaced flap. Now in bilaminar technique, most commonly a coronally displaced flap is used. We are displacing the, after covering the recession site with the connective tissue graft, we displace the flap coronally, means from the apical end, we will take the epithelium and cover the graft. So that is the coronal displacement towards the tooth. Okay. So in some cases, when there is no sufficient width of attached gingiva or coronally we cannot take the graft, even we can take the laterally displaced flap. But in most cases, we take coronally displaced flap. Okay. So the answer to this question is connective tissue graft and coronally displaced flap. I'll show you the image. So it will be more clearer for you. So here what is being done is, see here there is recession. Okay, here there is recession. Now what is done is, I hope you all are able to see the image. So what is done here is, whole of this, an incision is made, a vertical incision, crevicular incisions are made, the interdental papilla are left intact. This we are doing a mucogingival surgery. In periodontal flap surgery, when we are raising the whole flap, we will not keep the interdental papilla intact. But here you can see that the incision line is going like this. I'll just show you the incision line. Okay, like this. The incision line is going like this. Okay. Then here, then into the sulcus, then horizontally, then here, then this. Now what we will do is, we'll take a partial thickness flap. In question number 1, I have already explained what is partial thickness flap and full thickness flap. I'm not going to explain it again. Okay, you can go and see the video again. So in the full thickness flap, we are raising whole of the periosteum. In partial thickness flap, the periosteum is as it is. So we are just raising a partial thickness flap. So here you can see whole blood. This is because the periosteum is still intact. Now a pouch is created, right? A pouch is created. In the pouch, what we'll do is, we'll take a connective tissue graft. This connective tissue graft, it is taken from palate. This is the palate, okay? This is the palate, and this is a trap door technique. Through trap door technique, we are taking this subepithelial connective tissue graft, and this graft we are placing at this here. Here we are placing the graft like this. Okay, this is graft placed, and then the flap is displaced coronally, and it is, the connective tissue graft is covered with the flap. I hope you are clear with how a bilaminar technique is done. If you have any doubts, please ask me. Okay? Clear now? This technique, this image, is it clear? If you have any doubts, guys, you can ask in the group. Now, the next question is, now the next question. Which of the following plays a primary role in the pathophysiology of NUG? NUG is necrotizing ulcerative gingivitis. Which of the following plays a primary role in the pathophysiology of NUG? Option number A, bacteria. Option number B, impaired host response. Option number C, genetics. And option number D, both A and B. What is the answer to this question, guys? NUG is one of the most frequently asked question. Every year, 1 or 2 questions are coming from this topic. So this is a very, very important topic. Iske basics means you should be very much clear about the basics from at least this topic. Okay. So the answer to this question is, which of the following plays a primary role in the pathophysiology of NUG? The answer is the answer to this question is option number D, both A and B, right? Why both A and B? Genetics has no role. Genetics has no role in NUG. That you should be clear. In NUG, the main important thing is the host's immune system is weakened. Mostly in NUG, what happens is the host host's immune system is weakened. Mostly the patients of NUG will have some sort of immunosuppression diseases such as HIV, or they will be under stress. They will be living in poor socioeconomic status. Poor socioeconomic status. Okay. All these are the conditions, or they will be having some smoking habit or any other habit or disease which is causing decreased immune response. So, if the immune response of the host is decreased, if the immune response of the host is decreased, what will happen? The bacteria which is present in the host will be easily able to cause the disease. It will proliferate at a rapid rate because the body's defense system is not able to fight it, right? So, both for NUC to happen, the important bacteria which is present is the fusobacterium and fusobacterium, right? And spirochetes. Other bacteria are Prevotella intermedia. So all these organisms, what they do? Yeah, malnourished. In malnourished individuals. Malnourished, if an individual is malnourished means what? The individual is not having energy to fight a disease. Why the individual? We tell na the कुछ खाता पीता नहीं है इसमें तो एनर्जी ही नहीं है राइट कुछ खाता पीता नहीं है उसमें एनर्जी नहीं मीन्स द पेशेंट इज वीकेंड व्हाई द पेशेंट इज वीकेंड बिकॉज द सेल्स ऑफ द बॉडी आर not getting energy. They are not able to generate ATP. They are not able to generate ATP, so they are not able to function well, and therefore they are not able to fight the disease. In this case, the bacteria, which is importantly Fusobacterium and spirochetes. Now, these spirochetes and Fusobacterium, these bacteria, they proliferate very rapidly in patients who have decreased immune response, and thus they cause NUG. Okay. Now, the next question is, which suture technique is best suited for GTR and other regenerative procedures? So, GTR is a regenerative procedure. So, which technique is suited? Suturing technique. Which technique is suited for regeneration? Sorry, for sutures in regenerative procedure. Option number A, horizontal mattress. Option number B, vertical mattress. Option number C, loop. And option number D, anchor. Yes, the answer to this question is option number B, which is a vertical mattress suture. I'll show you what is a vertical mattress suture. In cases of diastema, we give horizontal mattress suture. In cases of GTR, we give vertical mattress suture. Now, in vertical mattress suture, what is done is from the buccal aspect of the tooth, vertical, as the name suggests, कुछ और याद रहे ना रहे, just remember vertically. Everything is going vertically. The needle is also penetrating vertically. The direction of the sutures, the direction of the threads will also be vertical. Okay. So in this, what is going on is the needle is taken from the apical on the buccal aspect from the apical into the coronal direction. It is penetrated in the apical direction. Then it engages the periosteum, and from the periosteum it comes out from the coronal aspect. Then it is taken interdentally, and on the lingual aspect also we take it from the apical to coronal aspect, engaging the periosteum. Then from we will again bring it back to the buccal aspect and tie a knot here. Okay. Now here you can see that whole of this suture lining is going vertically. And it is holding the flap. Why we are engaging the periosteum? We are engaging the periosteum so that the flap will stay there. Why we want to stay the flap there? Because there is a membrane inside. That membrane should not be exposed. If that membrane is getting exposed, it will come out. Regeneration will not happen. Okay. This is the horizontal mattress suture. This is important for your image based questions. Okay. So if you have any doubt, you can ask me now only. This is also important for IBQ. Okay, so horizontal, as the name suggests, the needle will be going horizontally. The sutures will, uh, here the sutures from the inside, they will go in the horizontal direction. So here you have to see the diagram of the suture or the needle. Here you can see that this is the buccal aspect as the needle is going, penetrating horizontally from one end to the other end. Then we take it back into the interproximal area. On the lingual aspect also, the suture needle is moving horizontally. Now just imagine inside how the suture will be like this, right? The suture will be in this direction. The suture will be in this direction, right? So it is a horizontal mattress suture. Then we come back again and we tie a knot. So this is your horizontal mattress suture. Okay. So with this, we have completed our session, and now I'll uh, take the doubts. Sorry, no. I'll take the doubts and also I'll explain about the lasers, hard and soft tissue lasers, which are the hard and soft tissue lasers. And one more thing was there, na? Okay, repair type. Repair के type नहीं है, healing के type है. Repair is a type of healing. Okay. So, I'll explain it to you. So, what happens is healing basically happens in four basic types, which is repair, reattachment, new attachment, and regeneration. These are the type of healing that are occurring in the periodontium, can occur. Most common type of healing that is occurring is repair. Now, what is repair? Repair is healing by formation of long junctional epithelium. Long junctional epithelium. So, what happens here is this is the tooth, and after taking, I'm not going very much into detail, okay, but after elevating the flap is elevated, then it is sutured back. Okay, the flap is sutured back like this. We are suturing back the flap. Now what will happen is, this is the epithelium. This is the epithelium. Epithelial cells grow at a very faster rate. It grows in a 1 or 2 day period. So within 24 hours, epithelial cells will start proliferating. Okay. So what will happen? These cells, when we have sutured back, the cells will proliferate and they will come down like this. They will proliferate and they will come down. And they will migrate up till the region from where we elevated the flap. So if the pocket depth was this much, right, and we have again sutured back the flap, the cells will migrate till the depth of the pocket, and again what will happen is, though now there is no infection, there is no disease, still there is an epithelium tissue that has formed. In place of epithelium, what was there previously? There was periodontal ligament, there was bone, right? There was bone. We needed bone, periodontal ligament, but instead of bone and periodontal ligament, what is there? There is epithelium. So, we call it as healing by long junctional epithelium. Healing by long junctional epithelium. Now, in reattachment, what happens is, if this is the tooth, okay? If this is the tooth. In regeneration, what is happening? See, normally what is the structure of the tooth? This is the gingiva, here is the bone, here is the periodontal ligament. But in healing by repair, and if there is bone loss, I'll say there is a bone loss. Okay. So this much is the reason of bone loss here. Okay. Now, if we have not done any regenerative procedure and we just raised the flap and we sutured it back, there will be formation of long junctional epithelium till here. This is what is repair. Now, uh, at the apical region here, at this apical region, there will be some remnants of periodontal ligament. There will be some remnants here of periodontal ligament. So what will happen is these remnants, these viable periodontal ligament fibers will come and they will start joining below to some extent. So that is what is reattachment. This is called as reattachment. Okay. In new attachment, you can classify new attachment as a type of regeneration only. But in regeneration, what we are believing is whole anatomy. Whole anatomy of periodontium is re-established. Periodontium is re-established means whole anatomy of periodontium. Established means having existed or whole anatomy of periodontium is re-established means what happens here is normal periodontal ligament, normal gingiva, normal connective tissue, normal bone. Everything that was there before can be regenerated, has been regenerated. Till now, this has not been achieved, but this is the goal. The goal of any periodontal therapy is regeneration, but we are not able to get regeneration means जो tissue, the tissue, if this was the bone, right? If this is the tooth, here is the bone, and over it there is a gingiva. Here is the periodontal ligament. The bone is here. Okay. And this is the gingiva. Now, what is happening here is this is the normal anatomy. Normal anatomy. But in bone loss, whenever there is a periodontitis, what is happening is there is bone loss, there is tissue loss. Okay. Such thing is there. There is deep periodontal pocket present. So what we do is in cases of regeneration where we want regeneration, what we'll do is we will place a membrane here. We will place a membrane here. We will place a membrane here. Okay. Now what will happen? These epithelial cells will not be able to migrate downwards and there will be formation of the bone. There will be formation of the bone. Okay. So here there will be bone formation. Here there will be periodontal ligament because the epithelial cells now have not migrated downwards and there are only osteoblasts which will come and they will help in the formation of bone. There will be pedial fibroblasts which will come and help in the formation of periodontal ligament. So this is what is regeneration and new attachment. Till now we are at the level of new attachment only. Regeneration is the goal, but whole anatomy of the periodontium we are not able to develop. Okay. I hope it is clear now what is repair, reattachment, new attachment and regeneration. Now we will quickly go through the hard and soft tissue lasers. I'll just enumerate the names as we are running out of time. Hard and soft tissue lasers. Hard and soft tissue lasers. Okay. Hard means that is able to cut the bone and calculus, remove the calculus, right? And soft means we can work on the gingiva and other soft tissues of the oral cavity. Now, basically, how lasers work is they are absorbed by the pigments. The main pigments that are present into the body are melanin. Into the oral cavity, basically, are melanin, hemoglobin, water. On the tooth, it is hydroxyapatite, right? In the calculus, there is chromogenic bacteria. So, all of these are responsible for absorbing the laser wavelength. There are different wavelengths of laser. The hard tissue laser wavelength that are used mostly is the Nd:YAG and erbium YAG, right? Nd:YAG and erbium YAG. Erbium YAG. Nd:YAG is 1064 nanometers and erbium YAG is approximately, it is more than 2000 nanometers, okay? So these two are the hard tissue lasers which can cut the bone, they can remove the calculus, and out of these two, erbium YAG is the best. Erbium YAG is the best. And soft tissue lasers, the most commonly used soft tissue laser is Nd:YAG can also be used for soft tissue. It is not like it cannot be used for soft tissue. It can be used. Erbium YAG can be used for soft tissue as well. But they are very costly lasers, so they are not that much frequently used. Most commonly, the soft tissue laser that is used is the diode laser. Diode laser has a wavelength between 600 to 900 nanometers. Most commonly, the wavelength that is used is, which is there in the BioLase also, and which I am using is 940 nanometers. This is the wavelength that is absorbed by the melanin pigment, that is absorbed by the hemoglobin, most commonly by the melanin pigment, and we can cut the soft tissues, but it cannot be used to remove or to cut the bone or to remove the bone and calculus. It cannot be used, okay? So this is the soft tissue laser that is most commonly used. Most of the clinics use diode lasers in their practices, okay? Any other thing you want to ask OMFS AIMS? If guys in detail you want to know about lasers, I'll make a video and post it, okay? Because laser cannot be covered in this much short time. So with this, we have completed the session, and if you have any doubts, post it in the Telegram group, and thank you so much. All the best.